Fletcher up, and welcome everyone tonight. I will try and keep some time at the end for answering questions, which means that I'll try and make my way through this at a relatively quick pace, but I'm happy to kind of send out slides at the end of this as well. I do have a bit of a resources page that I'll send out at the end as well, and I'd welcome any feedback in terms of things that you'd want to have that would be helpful from a kind of practice point of view. So without further ado, I will get started. Really just a bit of a run through tonight. ADHD, not spending too much time. I do have slides on the history and neurobiology, and I'll kind of go through them as in a way that hopefully is helpful without labouring the point. But I do want to get to some of the other topics in terms of things that we can be doing together in terms of treating ADHD. So you may already be aware of the history of ADHD, where it wasn't recognised formally by as a medical condition by the APA until the late 1960s. However, it's something that issues with this have been around for a long time, and originally more thought about in the 18th century. There's a lot of documentation, or some documentation, about essentially kids who were difficult to control and had difficulties controlling their own behaviour. That then morphed into talking about kids with hyperkinetic disorders and minimal brain dysfunction. The language of this has changed quite a lot over time, but really 1960s was where things started to be more formalised in the construct of ADHD. There was actually even before that, things like the stories of Fidgety Phil, written as way back, as far back as kind of 1844. Look, ADHD was first considered a defect of moral control and then a result of minimal brain damage. However, kind of further research really, and coming up to today, has changed our understanding of this such that it's looked at as a combination of genetic and epigenetic network issues, essentially, and we'll go into that a little bit today. This is an image of Fidgety Phil from back in 1844, which really outlines what we'd currently think of as a child or young man with hyperkinetic disorder or combined ADHD. So briefly, the kind of timeline. Sorry, I'm moving around this the windows so I can see properly as I go, but a bit of a timeline here that you can go through in your own time if you'd like. Of note, I think the racemic amphetamines actually have been around since 1937, and when they were first used to treat severe headaches, there was a discovery that they're actually quite helpful for academic performance and decreasing disruptive behaviour for certain children. Things then kind of paused a little bit in the progress of ADHD and ADHD treatment, where there was that period of the kind of Great Depression leading to World War II, and everything kind of almost got put on hold, and then really things picked up again in the 1960s onwards. And all the way through to today, where the DSM-5 has introduced slightly different criteria from DSM-4, including probably relaxing the age range slightly, but it hasn't changed too much from the previous version. Looking at the history of medications, we've gone from 1937, where we had the racemic amphetamine. Then we had Ritalin in 1955. We started getting the Ritalin slow release in the 80s. Adderall, which we don't have in Australia, which is kind of mixed amphetamine salts, in the 90s. Concerta then in 2000, Ritalin long-acting in 2002. 2002, we've also got Strattera, which is slightly different. It's obviously a non-stimulant medication. And then we've got Vyvanse from 2007 on, and Intoniv by the same company in 2009. One of the medications really that's not on this list and is quite important is clonidine, which came about in the 1980s, and really was the kind of original medication certainly for young children for treatment of ADHD, and would like to essentially think of clonidine. It's a alpha 2A receptor antagonist presynaptically. So it's a little bit like a cat with three ears, where one ear is kind of optimizing frontal lobe function. Second and third ears are a little bit of sedation and that blood pressure impact. So the tricky thing with clonidine, very good medication, but in terms of monotherapy for ADHD, talking about kind of 400 microgram doses, and the impact on blood pressure is a bit of an issue at that point. So not really used for that so much, but it is actually quite a good medication as an adjunct medication, or kind of a sleep medication. And we'll once again cross that a little bit later on. There's a fair amount of controversies at the moment around ADHD. There's seemingly a major kind of increase in people attending primary care and seeking ADHD diagnoses. There's the increased recognition of a different kind of phenotype in girls and young women, and we will that's probably a talk all by itself, but we'll talk a bit about that towards the end. And really one of the things that I think is coming up more and more is probably this, how frequently should ADHD actually be diagnosed and treated, and what are the actual cutoffs for that? So what I'd say to that is ADHD is probably better thought of as kind of in three clusters of characteristics that are dimensionally kind of continuous throughout the population, a little bit like most mental health disorders, things like anxiety, but also like some physical disorders in terms of blood pressure. We'll talk about what that means, but certainly it's not so much a categorical cutoff, although that's what you kind of see with the DSM criteria. So if we try to define ADHD, it's a tricky one. It's a complex neurological condition that involves problems with inattention and hyperactivity and impulsivity that are developmentally inconsistent with the age of the child or adolescent or adult. The main things with this are those kind of words, the developmentally inconsistent and the developmental trajectory, and also the impairment portion of that is major. So there are questions about symptoms and symptom presence without impairment, but I think that's a major thing actually for the DSM generally. This is a function of developmental challenges in brain circuitry in terms of monitoring and self-control, and it's essentially a disorder of attentional appropriation or attentional dysregulation. Of note as well, there are differences in reward processing, including the ability to defer immediate rewards for later gain. So that's quite a major one, the reward learning component of ADHD. And these are the kind of symptoms you would all be aware of: the impulsivity, hyperactivity, inattention, forgetfulness, fidgeting, making careless mistakes, acting without thinking, excessive talking, easily distracted, and lack of concentration. They comprise the 18 symptoms of ADHD that are present in DSM and ICD. Onto the kind of three main clusters that I would talk about in terms of those, that dimensional phenotype that's present across the population really is, so one is kind of goal-directed attention, and that's kind of putting your attention where you want it to be or where it should be rather than where it wants to go. The second is kind of inhibition, that is related to impulsivity, and this is also linked to things like fidgetiness and the hyperactive behaviors. And the third really important cluster is the motivation reward sensitivity cluster. So the difficulties with delayed reward aversion is a pretty major one, but we'll talk about kind of why that is. And really the motivation reward sensitivity cluster is probably the one that's most closely associated with dopamine in the frontal lobe. So it's an important one to have in your mind. I try to explain this a little bit with something that I call the desk analogy. So what this is if I ask all of you to look at this picture that's in front of us right now, your brain does some really cool things, particularly if you see this in real life. So in real life, what it will do is very quickly work out that this is a 3D kind of scene, unlike the one that we've got just now. But actually, these are different objects that are not just painted on a wall behind it. It'll figure out that there are objects of kind of different interest, so and urgency that are present in the environment. So if there was like a $100 bill sitting on the desk, your brain would probably look at that. If there's something really interesting playing on the computer screen, your brain would probably look at that. But essentially, without any points of major interest, what people will do is tend to kind of scan that, let their attention kind of wander across the scene, and probably kind of also go internal, so go into like a bit of a rest mode where they're thinking about other things. So if I try to get you to do a bit of work with that, where I say, look at that empty computer screen for the next 30 minutes and just focus on that straight for 30 minutes. Don't look at anything else that's there. And if you manage to do that, I will give you 20 cents in 3 years' time. This kind of sums up really what we're trying to get our brain to do when we're talking about goal-directed attention. So we're asking it to focus on something, and the brain has to kind of try and work out what's important about that if there's nothing obvious. And it also then has to inhibit itself from looking at all the other things in the environment and kind of stay focused on one thing. And that job becomes much more difficult if it doesn't know why it's doing that. And if the consequences or rewards are kind of very delayed or of low amplitude. So kind of 20 cents in 3 years sucks. Like that's an awful reward. If I said to you, look at this picture for 30 seconds and I'll give you $100 in your hand, it becomes a very different situation. It actually is less work for the brain to do that for a variety of reasons. So if you're trying to focus on something that is not obviously of interest, and you're trying to sustain your focus on that and tune everything else out, it actually takes a fair amount of energy to do that. So what we're talking about in terms of some of the phenotype variance over the population is how difficult or how kind of costly it is for the brain to do that. And there's a variety of things that will impact that, and as we'll come to a bit later. But with ADHD, what we're talking about is really people further along that kind of normal curve, where it's just more difficult or costly for them to do that. So they kind of get more cognitive fatigue and become more fidgety and can't really sustain that for too long. This slide is just to show, like, I could make this even more difficult if I had like a sign off to the other side that was kind of like, would you like to make an extra 100? Like, clearly this one's more colorful, it's got money, it's got all the kind of interesting bits. It actually just increases the cost. So part of this is to do with the environment that people are sitting in as well. And when we see our young people, they're quite often in clearly in kind of school settings where similarly the rewards are delayed and they're kind of like not obvious or a bit kind of sucky for a lot of them, where it's like, you know, if you pay attention to this really difficult subject that you don't quite like, your reward will be that you get a slightly better percentage mark in 3 or 4 months' time. And actually what's going on in the environment is a lot of more exciting things in terms of social interactions and opportunities, etc. So in a way, what we're trying to do is kind of support young people to develop the skills they need to do that. And here are just some of the things that can impact on the difficulty, the cost of paying attention. So there can be your kind of like, baseline or foundational cognitive functioning or executive functioning. They're really important. We'll talk about what that means a bit later. Emotional regulation, including mood and anxiety and kind of frustration tolerance, etc. And that overlaps a fair bit with executive functioning too. Anything like specific learning issues, vision or hearing issues, because if you think, you know, for someone with dyslexia, the amount of or difficulties with vision, they're trying to pay attention to a board that's kind of blurred and their eyes are getting tired, etc. It's a lot more difficult to kind of pay attention to that thing. The environment, how cluttered, how noisy, how interesting or urgent the environment is. How much sleep, nutrition and hydration people have, and a really big crossover with ADHD, probably bidirectionally, is sleep disorders. And once again, we'll talk a bit more about that, because that is something that I can certainly focus on, and I do focus on when I see young people up to adults. General things like physical state and medical issues. So to give an example, clearly people with low iron or low B12 folate actually struggle to make dopamine in the first place because they're substrates for conversion of tyrosine to dopamine, or that initial stage. And people with thyroid function issues will struggle because they have difficulties with receptor sensitivity to dopamine. So there are these kind of issues that actually make a big difference for, once again, kind of the motivation and goal-directed attention for people. And then finally, is the kind of strategies, approaches, understanding of things and kind of confidence levels with tasks. So sometimes it really is kids who actually just don't know or understand what it is that they're supposed to be doing. They're trying to pay attention, but they're actually quite lost. Or they are sitting trying to do, a really common one is kids who do better with things where their questions are quite contained and structured. So maths questions sometimes where they just have to work through a series of steps, versus things like an English essay where you just sit down and ask your question. You've got to kind of structure the whole thing for yourself. So sometimes the skills and strategies people have for regulating and approaching tasks, and these are kind of major things for paying attention as well. Like I said, we've really got that a different way of understanding this, a better way of understanding it is a dimensional kind of presentation. It's not so much do you have ADHD or not, it's kind of how much of a role do those difficulties with motivation, reward, sensitivity, goal-directed attention, and impulsivity and inhibition, and where are people on this? So, I mean, you're going to have people at the really extreme ends, but most people are somewhere in the middle, and that can really be affected both by development environment and kind of current circumstances as well. Really briefly, if we go through this reward and motivation cycle, I don't want to spend too much. Like I said, I'm trying to move through this relatively quickly, but what you've got here is the anticipation part is really to do with the nucleus accumbens, which is a kind of reward center, and its communication with the amygdala. So is this the anticipation a positive or an aversive one? It tries to kind of associate value to a stimulus, and that's to do with anterior cingulate cortex, where it's how much kind of value or valence does this stimulus have. That's then shunted up to the dorsolateral prefrontal cortex, where it kind of makes a bit of a decision about determining effort and how much worth things have. And then it moves on, that gets put through the striatum in terms of motivation and movement. So striatum is really your kind of like the part that made you all sit down and click on the link today, is striatal after all the other bits have gone on, and that obviously cycles around. So dopamine itself really is best thought of as let's say like an outcome learning chemical in the frontal lobes. So it helps with a kind of teaching signal, where it tries to reduce error in reward prediction. So if you go and do something for the first time and it's a bit awful, then it's kind of trying to teach your brain that that's not worth doing or is an aversive outcome. Or if the thing that occurs is good and worth doing, it will start to create a bit of a cycle where you look forward to that and are motivated to move towards that thing. So really it's trying to help accurately predict the occurrence of rewarding or aversive outcomes using the available information. That's to an extent what we're talking about. With that, what we get is when you have a positive experience, it's associated with D1 receptor, dopamine 1 receptor kind of firing, which is kind of then teaching your brain that this is a positive experience. Essentially what this slide is about is eventually what happens is that you don't need the actual reward anymore. Your brain is able to motivate itself really based on anticipation of the reward. And one of the things, one of the theories with ADHD is that whole process takes a lot longer. So it's almost like the reward or consequence has to be much closer to the actual stimulus event, and needs to be repeated more and more times for that to translate into that anticipatory motivation. When we talk about executive functioning and self-regulation, so these are major ones, and really major ones in therapy. I think that's certainly been on my mind in the a bit more of a feature at the moment. So what we're talking about with executive functioning is a bit of a combination of things like working memory, mental flexibility, and self-control. So really, it's the doing part of the dorsolateral prefrontal cortex when the brain decides I want to do something. And I'll give you an example. It would be, if I say to all of you right now, don't think about your toes. You're going to think about your toes for a little while. We all kind of will. Hopefully your brain will kind of tune that back out in a little while because it's kind of irrelevant data and just takes up a bit of attentional space. But if you've just stubbed your toe on the table, that's a very different thing. And really your brain shouldn't tune that back out, and it might shunt it up to the executive functioning portion of your brain, which is kind of like, maybe I need to move the table, or kind of take a slightly different route with things. So it's really into that kind of doing part of the brain. We'll see soon that one of the issues, particularly with that crossover with emotional regulation, anxiety, and executive functioning, is not necessarily that the hardware, so to speak, is the misfunction. It can be that so many things aren't getting tuned out that they're actually just overwhelming things like your working memory and task planning. So if you can't tune out all the thoughts about your body signals, what's going on in the environment, and your kind of thinking about the future and the past, so just as kind of like audio loops, then really your executive function is going to be trying to deal with everything all at once. And actually that's really impacts on all that as well. So really the tuning out and inhibitory parts are quite important. And like most other parts of the brain that we talk about, each type of executive functioning skill draws on elements of the others. So we won't go into that too much, but that should kind of make sense. Once again, working memory is just a part of the frontal lobe function that governs our ability to retain and manipulate distinct pieces of information over short periods of time. And I usually think about it or talk about it with patients a little bit like the RAM in a computer, or kind of the amount of tabs that you can have open at any one time. Once again, some people that's kind of a bottleneck in terms of their in terms of their cognitive functioning, but actually for other people, it's more about kind of the inefficient use of working memory. So if you have difficulties with attention and focusing, so that goal-directed attention, what happens is rather than kind of registering and putting information away neatly in an orderly kind of fashion, it all just kind of gets chucked on the floor drobe of your memory, so to speak, and is really difficult to bring back when you need it. So a lot of times then people start to use their working memory. They put everything into that kind of working memory pile just to try and hold on to it as an urgent fact, and it actually just kind of overwhelms that. Mental flexibility really is ability to kind of sustain or shift attention in response to demands, but also to do things like problem solving that comes up in different settings. And then self-control enables us to set priorities and resist impulsive actions or responses. So but children aren't born with these skills. They're born with the potential to develop them, and to some degree that's genetic. So I can see someone coming on the chat at the moment, but oh yeah. Really that there's that combination of development of executive functioning skills. It's actually really quite important by about the age of 3 to 5 as well. So there are lots of things that can impact on that early executive functioning development. Once again, it's something that develops across a lifespan and to some degree has plasticity as we go. But it really is important to provide the support that children need to build the skills at home in early care and education. And different kids are different. We'll talk about kind of the whole daffodil tulip kid at some point as well. Some kids essentially temperamentally are quite easygoing and just kind of settle into the groove. And for other kids, there's lots of things that can throw them off. Or for other kids, they actually just need a lot of explicit support around developing these skills. just moving on to the next bit, there's I put this slide in because there is a balance, and maybe to sum up some of what I've been talking about before, there's a balance between the frontal lobes and the limbic system. So that limbic system, it really is integrating a lot of information that's coming in from the environment and body, and is communicating with the amygdala to decide whether it's a positive or aversive thing that's going on. Communicating with hippocampus to kind of figure out whether it's been in this situation before, and deciding on how vigilant or how alert do I need to be. Is this kind of like I've just woken up and I'm watching paint dry, so I really can be half asleep, or is there kind of a tiger that's biting my arm off at the moment? It's trying to figure out what's going on in the environment overall. The frontal lobes then have a bit of a role in kind of tuning up and tuning down the limbic system as appropriate. So if you're falling asleep while the tiger's biting your arm off, that's not good. But if you're kind of, sweating bullets when you've just woken up, that's not good. And you do see this with kids with social anxiety, where they're kind of the hypervigilance, that limbic hyperarousal is quite prominent in inappropriate kind of situations. There's a real kind of fear and anxiety component to that. What happens is when the limbic system overrides the frontal lobes, like if it's really quite strong, the frontal lobes aren't able to tune that down, you get into kind of a limbic override state, which is that fight, flight, or freeze response. And part of that is because limbic stuff really is a little bit more efficient or a little bit quicker in terms of responding. It's a kind of doing mode. Really, the frontal lobes then aren't particularly good in terms of cognitive functionings, executive functionings, all kind of goes offline relatively. And this also kind of happens when people are knackered. So if you have spent all your energy coins essentially for the frontal lobes by the evening, what you'll find is people tend to struggle to tune out that limbic hyperactivation or hyperarousal, where they then kind of talk about anxious ruminations in the evenings. They struggle to kind of calm down and calm themselves and the limbic system down in order to go to sleep. And once again, you see this sometimes temperamentally. Some kids are quite active and running around trying to do art projects at kind of 9 p.m. or 10 p.m. at night. It's the same thing if you kind of get home from work and you're absolutely shattered from a long shift and frontal lobes are just absolutely knackered. It takes you a bit of a while to actually wind down the limbic system, and that can really affect sleep. But it can certainly affect, even during the day, things like that directed attention and ability to kind of inhibit those kind of limbic striatal bits that are about movement. So if you imagine that kind of seesaw going up and down, when the frontal lobes are kind of down, the limbic system really goes up, and you get that hyperactive, fidgety, stimulus-bound kind of alertness. Looking at the top-down inhibition, it's really, there's a lot of areas for this, and I won't go into them too much, but it's just to kind of give you a bit of an idea of the bits of the brain that are involved in the top-down inhibition for things like goal-directed attention, so kids sitting down to study. And the prefrontal cortex requires a proper level of catecholamines for optimal function. This is really important with medications. So we talk about this kind of Goldilocks zone, which is in the middle of that curve. So too little D1, which is kind of that motivational kind of reward learning chemical, if I want to put it that way, or the alpha-2A receptor norepinephrine or noradrenaline, which is kind of to do with the top-down inhibition of limbic system. Essentially what you get with too little of that is the kind of unguided, distracted responses. So people's brain just wandering everywhere. They're kind of internally or externally just kind of daydreamy, and really find it difficult to figure out what they're doing. Kind of this is the kind of just woken up watching paint dry mode, essentially. In the middle, there's a zone where you've got enough to kind of motivate, anticipate, direct attention appropriately, kind of do all the flexible cognitive parts to whatever degree people are able to. But then actually kind of, if you keep going, it tips over. So you start getting too much dopamine. You actually switch with more noradrenaline, you switch to alpha-1 and beta-1 receptor agonism, which is more that kind of anxious response, sweaty kind of palpitations, and more what we call misguided attention, where people are once again kind of inflexible, but this is more that kind of stimulus-bound, everything in the environment, just kind of jumping around from thing to thing as stimuli are coming up in the environment. when people's frontal lobes are tired, they can actually just kind of flip-flop between these two states, as you'd imagine. So that real anxiety and kind of dreaminess because they're knackered. The reason this is important, though, is that too much stimulant, if people are kind of middle onwards, actually increases that activation state. And actually what you'll get is more anxiety and more mental inflexibility, rigidity, and stimulus-bound response. So it's actually not just about putting in more and more stimulant. Actually, that can start to kind of have negative effects in terms of what we want people to be able to do. Look, ADHD seems to be quite a common, certainly when kind of operational diagnostic frameworks are applied. It seems to be relatively consistent, about 5% of people in terms of children and adolescents across different countries. Really, how that's dealt with in different countries is part of the big difference. So either how they kind of screen and or test for ADHD, or how they treat. So certainly US, there seems to be more of a emphasis on kind of biological treatments, and Europe seems to be more of an emphasis on psychological treatments, which is in keeping with most other mental health disorders. So although ADHD seems to be more common in males, and certainly in the kind of clinical populations, I think one of the things at the moment is kind of recognizing that different phenotype that seems to present with girls and women. So, and symptoms in a child might change as a child grows older. So usually what we see is more kind of persisting inattention rather than persisting hyperactivity as people age. That can be just as impactful for adults. Etiologically, once again, like most things in mental health, we're still kind of figuring it out. And part of that is to do with, well, lots of things really, but they're quite complex disorders most of the time and quite overlapping in lots of ways. Obviously, we're talking about kind of syndrome diagnoses rather than anything else. Of note, ADHD shows a strong heritability rather than one that we would consider inherited. And I think that's a significant point to make. So really the genetic contribution seems to be high, and it runs in families, and it's kind of like seems to be almost like a phenotype that runs in families. Not that every family member is the same, in that if we look at that kind of normal curve and what we're talking about, it's like anything else, phenotypes run in families, but they're not exactly the same across different members of the family. There's lots of, there's rare genes of high effect, and there's lots of common genes of very small effect, and that's once again pretty common for mental health disorders. And there seems to be a significant component of development in epigenetics that goes on as well. So I don't think anything new with that. The developing brain has high plasticity, and the external world is involved in its shaping. And once again, it's quite a busy slide, but off to the kind of down the corner there is something called a buffer transducer model, and it's really what that is about buffering genetic predispositions, or kind of transducing in terms of the environment for young people, but actually all the way through. People exist in systems rather than being automatons who are kind of separate from what's going on around them. Of note, things like childhood maltreatment and trauma affects the HPA axis. And what actually seems to happen here is the feedback loops in terms of cortisol become less sensitive with prolonged stress. And so there's less regulation of noradrenaline in the frontal lobes. And if we go back to that picture I was talking through before, that means that there's dysregulation or too much noradrenaline quite often in the frontal lobes, and in that kind of over alert kind of fear learning mode. But infants and caregivers are involved in a dyadic process that's referred to as a mutual regulation model. So it's kind of bi-directional. I think if kids have really difficult temperaments in terms of being really active kids, or difficult to settle, or have difficulties with their emotional regulation from day one, that kind of goes around in a bit of in that dyadic kind of circle back and forth. Won't go too much into this slide, but neuroimaging studies, there seems to be, particularly in males, I would apply this rather than females, tends to be slightly different, but we talk about the kind of developmental deviation model a little bit more in males with the kind of alpha slow waves that are quite pervasive in the frontal lobes that are associated with default mode networks. So I mean, none of this stuff is entirely I would say like certain, but just looking at kind of patterns of things, we're a fair way off, I think, still from being able to do a blood test or a neuroimaging result, neuroimaging study to kind of diagnose ADHD. Genetics, we've talked about kind of being heritable rather than inherited. Perinatal risk factors that are pretty major to try and cover are things like prematurity and low birth weight. Temperament and attachment, as we've spoken about, can be problematic in infants who are later found to have ADHD. So you quite often can see that from quite a young age. And once again, that can kind of circle around in terms of their needs and having those needs met or not. Childhood adversity can be have a major impact on the development or buffering of ADHD phenotype. And once again, really a big time that we see things, people struggling is, entry into high school where the executive functioning load goes up massively at the same time that people are hitting puberty and the brain's kind of rewiring and they're trying to individuate away from families. And all of a sudden they've got, instead of one teacher in a kind of routine kind of controlled environment, actually they've got multiple classes, lots of assessments and all these kind of things. So that once again can impact in lots of ways in terms of stress and sleep, and then kind of go around and really say potentiate or show up any vulnerabilities that are existing there at that point. So just getting onto this idea of like daffodil versus tulip kids, it's probably one that you've all come across quite a lot, but just the idea that daffodil kids are generally ones with what we call like an easygoing temperament, where, I mean, daffodils is the idea that they can essentially grow out through the cracks in concrete, and they're lovely flowers. Tulips require much more in the way of, I'm awful at gardening, by the way, just inside, but tulips require much more kind of effort and explicit care. Also make for kind of beautiful flowers, but the skills needed to what would say like create a good tulip are much more. And I think this is certainly a thing for, if you think about kids who are further along that ADHD phenotype, quite often are kids who have more explicit needs to help them develop their emotional regulation and executive functioning as they're growing. And quite often they've got adult parents who they either have ADHD. So a really nice line from the Smart But Scattered books are, people will really struggle where the parent is either the same as the child, because it's difficult to kind of, if you're both kind of doing the same thing, you both have the same strengths and weaknesses, very difficult to kind of see what the alternatives are, or where they're really far apart. So if, the parent is ultra organized and obsessional and the child is kind of complete chaos, it's very difficult to kind of empathize and understand what's going on there. So really sometimes it can be that difficulty of essentially mismatch, and really the kind of knock in confidence that comes with that over time as well, which is really quite sad to see at times. Really some of the assessment and treatment is actually just helping people to regain confidence with some of these bits. Neurobiologically, once again, quite a busy slide. I'll leave you to read that in your time, but of note here, the inattentive subtype and the combined subtypes are more associated with academic impairment and difficulty, and the combined and predominantly hyperactive impulsive are more linked with kind of behavioral and kind of conduct issues, so more the things that will get people in trouble. I won't really go into it much more than that, but inattentive ADHD is a pretty major thing, and there seem to be two relatively distinct phenotypes of subtypes. We've gone through this a little bit, the top-down inhibition. There are three kind of proposed networks that are quite important in ADHD. So one is the salience network, and really this is involved in detection of internal and external stimuli that are important to direct behavior, and kind of there's a bit of communication with the amygdala. Is this a positive or aversive kind of thing? That's in communication with something called the central executive network, which is your dorsolateral prefrontal cortex, and it's thought to be the kind of seat of executive functioning properties. And then there's a third part called the default mode network, and this is really your kind of resting state, drifty, dreamy, not using up too much energy and actually just kind of chilling out mode. What's supposed to happen is the salience network makes sense of what's going on and lets the brain know whether it should be in the central executive network dominant mode or the default mode network dominant mode, because those two are opposites essentially. So if the central executive network kicks in to kind of get things done, that should actually kind of inhibit the default mode network and vice versa. And one of the thoughts with people with ADHD is there's less difference between those two modes, or it's more difficult to shift between them, so that people are still kind of in that drifty, dreamy, kind of intrusive thinking and other bits state when they're actually trying to concentrate as well. The two tracks aren't separated enough. In terms of ADHD diagnoses, there's a really good new guideline that's come out from ADPA, which is available online, and you can just register and get that one. It's kind of national Australian guidelines. I would encourage you to have a read through. There are multiple issues in the diagnosis of ADHD. So thinking about kind of kids presenting with higher IQ, where really they either have bottlenecks in their kind of in some of their cognitive functioning, so things like working memory or processing speed, but they're more seen to be inconsistent performers who just don't try sometimes. Really what happens is they're knackered, and parts of their brain are learning that things are too much effort in terms of structure and organizing quite often, but sometimes they can manage bits, or where people just overall have a kind of cognitive disorder, where they struggle kind of pervasively. Other bits that are comorbidity with ADHD, language difficulties. So there's things like hearing, but there's also language difficulties in terms of speech and language processing, and specific learning difficulties there. And that tends to be a bit more of a thing with seemingly with girls and women presenting with ADHDs. Certainly the kind of impulsivity seems to present more in a kind of talking rather than other physical behavior way, but given that they tend to present more with inattentive presentations, there's quite often a bit of difficulty with hearing and verbal processing. And this is actually a major thing for people with mental health difficulties overall, is that it's not necessarily they don't understand what's going on, but actually just sometimes the processing speed of that can really impact and either overwhelm or kind of tire everything out. Major interaction with things like anxiety, trauma, OCD, depression, behavioral problems, interpersonal problems, and kind of just general kind of chaos or inconsistency. Sleep difficulties is major, tic disorders, and substance misuse and TBIs, which are probably less common. Other kind of physical and mental health problems, anemia we've talked about a little bit, and nutritional intake difficulties. And this is another one for teenagers where they get up and don't have breakfast and go to bed at 3 a.m. playing video games. Kind of bi-directionally a bit of an issue in terms of attention. There's not a single test for ADHD. It's often seen as a comorbidity, and a comprehensive evaluation is necessary, not just to establish a diagnostic label. And I think that's one of the points here as well, is it's not just about the disorder or kind of treating the disorder. It's about helping the person with the disorder in their context. So really a comprehensive evaluation is the bit that kind of figures out, if you have 10 people with a diagnosis of ADHD in a room, they're going to have 10 different sets of needs essentially in terms of ways to approach that. So there's lots of ways of doing a comprehensive evaluation. I'll talk a little bit through. This is from CADRA, and this is just a really nice algorithmic approach to childhood ADHD assessment, which is good and includes things like not just a symptom behavioral screener, but also teacher assessment forms and like symptom rating checklists, which kind of really give a bit more of a granular overview of what it's like for that person. But then obviously goes through things like the medical review before doing ADHD specific reviews and treatment recommendations. This is one for adolescents, and there is one for adults that will come up a bit later. In terms of some really important medical conditions that can cause or exacerbate ADHD, so hearing, vision impairment, it's pretty obvious. Thyroid dysfunction we've talked about in terms of dopamine receptor sensitivity and overall kind of fatigue and sleep and other bits. Issues with hyperglycemia or diabetes, severe anemia, and B12 and iron issues. Lead poisoning, wouldn't see too much one thing. Sleep disorders are a major and really common one. and then think about medications and non-medication kind of substances. We're not seeing too much in the way of energy drinks anymore, which is I'm really relieved about, because about, I don't know, 10 years ago, I'm seeing a lot of that in high schools, people just kind of having lots of Red Bulls and Monsters. I think it seems to have faded away, but I think there's a lot more, it seems to be a lot more kind of vaping and things going on instead at the moment, which I prefer really. In terms of tools that you can use, so we've got things like the Connors 3, which I won't go through. It's kind of paid assessment. There's the Susan Young's ACE, and it's a really good assessment we'll talk about a little bit today. It is available for free, and it's a really good one to have, and it's the one hopefully you should all have at the moment. There's a great YouTube video if you want to go and have a look in terms of how to use or go through that ACE. And then we've got the Diva Young Person or Youth Diva, which is, once again, I think it's about $10 or $20. It's not too expensive, but we won't go through it today. But these are 3 really good instruments for doing a pretty good assessment of ADHD. And just kind of going through bits of the ACE tonight. We've got, starts off with demographics and into kind of early risk factors. So in particular, I've highlighted there the premature birth and low birth weight as major things. Of note down the bottom, there's the, has the child had their cognitive ability assessed? And I think one of the things here is like the controversy with neuropsychological and psychoeducational assessments, which are, there's difficulty maybe accessing the sensitivity and specificity isn't such that they can be used reliably as ADHD diagnostic evaluations by themselves. They can kind of help with understanding a bit about, does this seem like ADHD in terms of the profile that people are presenting with or not? And they can identify other things or kind of help to identify other things, including things like specific learning disorders. But probably one of the really great uses of them, I think, is to identify areas of strength and weakness for people, because we're all very different, and that actually really helps from a strategies and approach point of view. So I actually do think they're worthwhile doing, although once again, there is just limitations around access and cost. In terms of medical history, we've gone through bits of that up until now. I've put this one in just in terms of adverse child event screening. It's a little, there's obviously the kind of ACE questionnaires, and this is just a series of questions that are sometimes quite good to kind of screen for adverse child events. Then it has kind of sections on education. So really just kind of trying to kind of go through the child's background and really get a good understanding of what's presenting, rather than just a symptom-based kind of approach to things initially. So and really thinking about child's friendships as well. Some of this is also kind of hopefully flagging up as we go if there are any issues with things like long-staying developmental social difficulties. Get a bit more of an idea of flavour of them as you're going through the ACE. And then things like family members diagnosed with ADHD or other neurodevelopmental disorders, the family members with a history of mental health issues, that kind of maybe flags up if there are kind of stressful experiences going on for the family generally. And then just kind of the educational, occupational history and attainment for mum and dad, because once again, a lot of this is kind of under-recognised, sometimes difficulties for parents with ADHD or other disorders. I won't go through all the different, obviously 18 kind of diagnostic criteria, just because that would take up a long time, and you can just go through it yourself. But what I will say is, if you look at each of the criteria, they're really good in that they give some good examples of what that can look like for a child. So really what you're looking at is this happening across at least 2 settings, and is it causing impairment? So is it a continuous kind of difficulty for them? But really nice to kind of have some examples of that you can explore a little bit if you're going through these with a child. I suppose with this, it's if you're wanting some thoughts about what kind of questions to ask, that's what I'd kind of pull from the ACE, not to kind of sit and go through it, because I'm aware that from a time point of view, it's quite a long thing to go through. But of note, things like this, where difficulties with sustaining attention in tasks, really that this is giving an idea of that kind of two thought train analogy. So for people where they've got what they're trying to focus on at the moment, and the other thought train that's happening, which is kind of like, what am I having for dinner? What's going on right now? Other things happening in the environment. And for people with ADHD, really sometimes difficulty turning the irrelevant one down, or kind of separating those two out, where they're just kind of getting both things happening at the same time a lot of the time. Like I said, I won't go through, but it does cover obviously all the diagnostic criteria for both inattentive and then hyperactive impulsive components. There's some really good articles on executive functioning. And once again, I think this is a major area of kind of treatment, or if we're talking about what we're trying to do with medications, part of it is to help with the emotional regulation, impulse control, and what I call like almost psychosocial rehab, or optimizing of a situation for young people, adolescents and adults, where they can actually have enough energy and cognitive energy left to actually do the strategies and things that and learn strategies that are helpful to kind of scaffold them in different situations. Won't go into this too much, but it really is, you can think of it in multiple ways. One is just to kind of like the idea of like an air traffic control system, where things are kind of landing and taking off. So it's part of it is kind of monitoring all those things going on, and kind of prioritizing and landing the plane safely, as this says. We've already spoken about people aren't born with executive functioning skills. I've yet to see a baby with incredible executive functioning, but it should develop kind of over the course of people's lives. But really, there's a rapid development, like a lot of things, kind of between the ages of 3 and 5. And so one of the things, reasons of pointing that out is if there are major disruptions in terms of the child's health, or kind of stresses in the family home, or kind of difficulties for people with even kind of parents with illness or mental health issues at that time. This is important stuff to have in the history taking or understanding of the case, because that's a critical time for these things to develop. Once again, won't go into it, but there's a lot of parts involved in executive functioning. There's some really good books on this that are on the resources sheet at the end, including things like just screening tests and other bits to kind of rate. So what you'll see is most people, it's not like they have pervasive executive functioning difficulties. It'll be like certain areas of them. And it might be, to give an example of something like task initiation, it might be that people have real difficulty with breaking down a task into steps that they can take in order to kind of complete that, which is really what task initiation is about. But a lot of the time what you'll see is actually it's, under ideal circumstances, kids can do the task initiation stuff and break a series of tasks or steps down. But in a real-time environment, that function is just getting completely swamped, either by trying to do too many things and not knowing how to kind of organize that, or just being swamped by kind of anxiety and overwhelm, where it's difficult to kind of find their feet and pick a starting spot with that. So what I mean by that is sometimes it's the actual property, and other times it's the kind of how it's being used that's the difficulty. I mean, look, executive functioning and self-regulation are transdiagnostically really important. They're important for like a lot of outcomes for people at all ages, but also in terms of kind of development and skills attainment as people go through things like the social, occupational attainment, and then kind of building up that sense of themselves, so confidence and identity that goes with it as well. It impacts on things like adaptive behaviors, as well as just the kind of functional and academic attainment. So look, as clinicians, what can we do to advise parents? I mean, part of this is to be having these conversations. And I know this is a difficult one sometimes, where you see people maybe as a one-off, and actually kind of establishing enough of a therapeutic relationship to be having these discussions over time. It can be really tricky. But what I would say is we can talk to parents about the fact that, look, in terms of optimizing what people have, some of that is that children are more likely to build effective executive functioning skills if the important adults in their lives are able to model the skills, try and provide kind of routine and consistency, that kind of helps, obviously, with the prediction parts of this. Engage in activities in which they practice those skills rather than just learning about them. Providing a consistent, reliable presence that young people can trust, guiding them from complete dependence on adults to gradual independence. It's a really major one for adolescents. And protecting them from kind of violence and adversity, to mitigate both the kind of overall stress that disrupts brain functioning, but also to kind of try and help them to not develop kind of aversive labeling to kind of non-aversive experiences. So once again, another good article just about executive functioning and emotional dysregulation, or more kind of emotional dysregulation difficulties in adults, and how that kind of impacts in terms of ADHD. It's really a major part of ADHD. It's not just the inattention, but the emotional regulation component. There are some really good books here, just briefly. Smart But Scattered is fantastic, and it kind of comes at different age levels, from kids up to adults. The DBT workbook for ADHD is really fantastic. I've got that on the resource sheet at the end. And then Lydia Zlovska does a really good mindfulness prescription for adult ADHD. What we're talking about with things like mindfulness are actually attention training. And so Lydia Zlovska has actually got a good kind of online course on her website that you can do as well. So with medications and kind of strategies, what we're really trying to do is scaffolding executive functioning and self-regulation. So either in order for those things to develop, or to kind of scaffold where they're at that time. What I want to point out here, though, is, and I'm not too sure if there's the right place to put this, but something called Fould's Hierarchy of Psychiatric Disorders from 1970s. And what this is looking at is maybe a way of thinking about the different levels of things to approach just generally with mental health. So the reason I put this up here is to always have that kind of organic component at the top, and really that organic component includes things like sleep, nutrition, energy drinks and all those kind of bits, but also making sure that from an organic point of view, if people are really iron deficient, they're going to have not a very good response to stimulants, because if you take a medication just pushing dopamine out of the neurons into the synapse, but you're not making it very well, you're kind of starting off on the back foot with that. So really, there are a lot of things that we can do to try and optimize this before we kind of start on medications. And then obviously, as we work through, we're thinking about treatment of comorbidities and kind of the order that we prioritize those in as well. Really nice website. The Choice of Medication website has some good information sheets about all the different medications, but also a really nice section on ADHD, including the kind of different types of medications that are typically used for that. It's a good comparison chart. I'll leave it on here. I won't go through it too much, but it's a good website to use and to give people handouts from. This is from Stowe, and it's really going back over a little bit of that idea of the kind of what to say, like a metronome, or kind of the arc that we're talking about with kind of deficient arousal versus excessive. So really the reason this is up here is just to keep coming back to the idea that from the kind of left hand, like asleep, all the way up to alert and awake, this is kind of stuff that stimulants will mainly help with. But from awake and alert all the way to excessive arousal, this is where we can start to get in trouble with adding in stimulants. And in fact, they can, if people are either really sensitive to that, or they're having too much stimulant, you'll see that it's much more kind of, the anxiety is much more that, the presentation is much more one of anxiety, and once again, still difficulties with attention, but they're not going to be helped by adding in more and more stimulant. In fact, they'll get worse with that. So theoretically, what you've got is norepinephrine is to, or noradrenaline is to increase the incoming signal. So help that to kind of be picked up, whereas dopamine is to kind of decrease the noise. So really both quite important from a goal-directed attention point of view. And I think the focus, clearly at population level kind of stimulants seem to be more helpful. They're quite broadly helpful for not just ADHD, but certainly from an ADHD point of view, they have they're in the winning seat, I suppose, from a medications point of view, but it doesn't mean they're always helpful for people, and it doesn't mean they're helpful just purely as monotherapy. So if you look at this, sometimes actually what is helpful to do is to add in something to help with that top-down inhibition, so that kind of limbic emotional regulation component, either as the main thing that you do, or certainly as something you would do before adding in any sort of stimulant medication. And what we've got here is atomoxetine and guanfacine of note are quite good at both. So kind of trying to bring that back towards the middle. Probably not as good as stimulants from the left side up, but they kind of are better at maybe regulating things in the middle a bit more. Management of comorbidities, and this is from Sunil Rege's PsychScene website, which is a great one to have a look at as well, and I've included in the resources. But just talking about really management of comorbidities. So we've got kind of like the comorbidity seems to outweigh in terms of current symptom burden. You actually treat that first. So if people are incredibly depressed, etc., that's your kind of first target of treatment. And then obviously just has quite a nice algorithm for kind of choices of medications after that. Also, really, we should be pairing medications with a psychosocial approach. This is really, really important in that, if we think about medications, that they generally are as kind of, they are both helpful from a symptom reduction point of view, but they are also kind of facilitators from a recovery point of view. But they don't necessarily do the recovery by themselves, and they're not necessarily kind of sufficient for that either. So there are things that can help and reduce the need for medications or reduce the need for higher doses of medications. And this can, certainly for people with things like ADHD, some of this can be around helping with emotional regulation and that kind of behavioral regulation side of this as well. And we'll kind of talk to patients about the idea that, if you're really stressed out and you are on a phone call with someone, you'll find yourself kind of pacing around. It's the same for kind of people where they're agitated and anxious in an environment where they're getting quite fidgety. Sometimes that bit of movement helps them to regulate and stay on task. There's also things that can help with kind of working on and developing emotional regulation and attention. So strategies to kind of support that. Sleep hygiene and just generally getting good sleep is major. And it's not just about enough duration of sleep, but it is also about kind of getting into the kind of restful phases of sleep enough over the course of that. So, kids who are talking about waking up still absolutely shattered and kind of waking up then and kind of really getting their brain online about midway through the school day, or kind of kids who are having difficulties with things like sleep apnea or really vivid dreaming and restless legs and all these bits are indicators that they may need some additional kind of help with sleep, and certainly that is almost a primary approach before necessarily going to stimulants, although stimulants can kind of help a bit with that too. There are other things like we've got their relationship work and kind of helping the family. Quite often there's a fair amount of, let's say, like stress points in the family by the time we see them. So things that have been happening over and over again. And so just kind of reframing and helping with that can be really helpful. Exercise, routine, regular eating is major. So that kind of not having like crashing blood sugars throughout the day, or kind of, having a big meal and then going for an afternoon nap because you haven't eaten anything before that. So, I mean, the example I'd give is like, it's not good. If you tell me that you're hydrated because you don't drink anything through the day and then you drink 3 liters at 10 o'clock at night, your hydration during the day is probably not great. But once again, that just adds to cognitive fatigue during the day because it's trying to run on less. And I can see everyone's picking up their water bottle now, which is fantastic. Love to see it. Look, a few special populations, and we're quite near the end. Keen to take some questions pretty soon, but I am aware that they're kind of like probably questions or thoughts around some special populations that are current focus in ADHD. I'm more than happy to do like a separate talk on any of these individually if people want to, but I'll run through a few of them that I think are of interest at the moment. One is clearly kind of adults presenting with ADHD. It's a big thing more and more recently, and probably more recognized that ADHD is not just a childhood disorder that kind of goes away. So there's continuation of ADHD symptoms into adulthood, and there's the kind of under-recognized ADHD that where people have kind of maybe compensated enough. Once again, if you think about that kind of phenotype, where they're not at the extreme ends, but then all of a sudden they're trying to do things like go to university, have a family, work a job at the same time, and the executive functioning load, etc., all goes up, and all of a sudden they're struggling. Their coping strategies aren't enough for that. There's a more kind of controversial like adult onset ADHD, but really a lot of it's talking about that kind of persistence into adulthood. With the DSM, instead of 6 out of 9 symptoms, it requires 5 out of 9 for each subtype domain. Some flags are here, and look, once again, these are from CADRA, but also from the Sunil Reggae site on this, which has got some really good articles on this, and is freely available. I would encourage you to have a look at this from a mental health point of view generally. It's a great resource. But just some kind of red flags for screening for adult ADHD. Doesn't mean that it is, but just some pointers that may be worth then digging around with, particularly if you've got someone who has really that long-standing difficulty with depression, anxiety that's got features of this as well and is not responding particularly great to just the general straightforward antidepressant approach. ADHD is a kind of lifespan type disorder, so it presents in different ways at different times. You'd imagine there's different things going on. So, that really the adult side of that is that we tend to see the kind of inattention and executive functioning difficulties that start to cause more of an issue. There's more of a risk of substance abuse. In fact, it's much, much higher in people with ADHD. Not to say that that's inextricably linked, but can be a major issue. It's jumping around, isn't it? And then just generally things like relationship issues, mood and anxiety difficulties, and impulse-related difficulties in terms of accidents and traffic violations and other bits there. The overall combined for kind of quality of life issues. So, this is from the CADRA again. I did say there was an adult diagnostic algorithm. It's not exactly overlapping with the Australian National ADHD guidelines, but it's a really good and quite comprehensive one. The Canadians make some good CPGs. Second kind of special population of interest, I thought was kind of ADHD in girls and women. It's a current topic with things and people kind of presenting, talking about the different phenotypes. And there are some thoughts about what this is about on a general kind of population level, so as groups, but not necessarily kind of for individuals. But it seems to be that there is more of a developmental deviation model in males presenting with ADHD. And there's things around this in terms of effects of testosterone in the brain and kind of maturation and development. And really some of that kind of striatal, fidgety, hyperactive type difficulty there as well. Whereas there's some indication that for girls and women, there's more of a tendency for it to involve the inattentive type presentations and present with like less of a tendency for the hyperactive behaviors in adolescence, certainly, and kind of more of the difficulties with emotional dysregulation in adolescence and onwards. And part of that is probably multifactorial in terms of difficulties recognizing and picking up and therefore supporting girls and women so young girls at that age where they're struggling in school, but they're just kind of drifty and dreamy, or they're not causing any trouble, so no one really focuses on them for that. But there are also the differences with estrogen progesterone cycling when it comes to adolescence. So estrogen is a kind of pro-cognitive hormone, if you want to think about it that way. It's helpful from an attention cognition point of view. And it seems to be a fairly major overlap with things like PMDD, but also with people presenting kind of perimenopausally with onset of depression and kind of ADHD type symptoms. And I think, once again, we can talk about this at a different time if we want to, but really probably slightly more recognition and understanding of that as we're going on as well. There's a paper on this from 2020, which is quite nice to read. I won't go through it, but if you wanted to look at that, it's in the slides. And once again, I've kind of got the link to this one in the slide, which is just a bit of a table that, look, this is not absolute. And obviously, you have discussions with patients about this as well. And it's not every single person, there's that different phenotype or different response to things, but just some of the kind of general kind of differences that seem to happen and account for some of the differences in presentation. Last but not least is ADHD and autism. So really with DSM-5 and allowing for that co-diagnosis, and really that makes sense in that they shouldn't really be mutually exclusive. There's a significant overlap with executive functioning difficulties in autism as well, and there is a response to stimulants that can be quite helpful. The differences, I think, seem to be that there's the study with methylphenidate, sorry, it'll come back to me in a bit, seems to be that people with co-occurring autism and ADHD seem to be more sensitive to that stimulant kind of tipping over to the right and getting that kind of anxious like side effect response to stimulants. So just have to be more careful with them, and tend to be less effective in terms of helping overall symptom burden. So the other part that goes with this is that there seems to be a fair amount of autistic children who have difficulty or differences in melatonin secretion and kind of then sleep difficulties. So it's things where we'd think that sometimes buffering a bit with actually really quite like clonidine. It's quite a useful medication, certainly helps from a sleep point of view, and from a sleep point of view that then indirectly helps from a concentration and mood regulation point of view the next day, even if the clonidine isn't still ongoing, because it's got a 13 to 16 hour kind of a window. But really what you might be thinking about with kids with autism is just not to ignore them from an ADHD point of view is really a key thing, but also just that buffering might need to happen a little bit more with medications or carefulness with stimulant meds. And then there's a whole bunch of other topics. I've kind of covered ADHD in girls and women and adult ADHD and ASD really, really briefly. But each of these potential kind of talks of their own, to be honest. There's major overlaps with things like EPD and BPD and eating disorders, bipolar disorders, clearly substance use disorders. So I'm more than happy to chat about that at some point if we need to. OCD and tics and epilepsy are specific things as well in terms of approaches to them. Like I said, I've got a resources page. I'm happy to kind of send it through. If there's any other bits that people are wanting me to put on there, things that would be useful in your practice, please let me know. I'm happy to add to that. But these are just some really good studying resources that you can print out and give to parents. Even if child doesn't have a diagnosis of ADHD, there's some really helpful stuff on there in terms of things like the CADS, for instance, has parent nights about sleep and emotional regulation. Cycling Hub we've spoken about is fantastic. The Raising Children Network is great, and there's some really good books on for parents and kids and things like mindfulness-based stress reduction and like I said, Lydia Zalovska's bits there as well, and the fidget tool. So I'll send that through along with the slides, and that's about it. Look, I've put this one in at the end here as well. In that the idea, I think, would be that this is an area of need for adolescents and young people and their families, really. So I think there's some discussions we've been having about kind of future directions at Ramsay Clinic Hollywood, just about, how do we help out either with kind of inpatient or day patient based approaches to this. But like I said, more than happy to present on any of the specific subtopics in future if we need to. Well, a bit over time, but I've got about...
Richard, we do have a few questions in the Q&A box, if you're able to access those. Oops. I think you might be muted.
Sorry, I must have muted myself there.
Yes.
Yeah, I'm just saying, I'll start with Danny's question first. So, yeah, I think, look, what I'd say to this is you're wanting to kind of assess this over different domains if you can from a, so question obviously about how do you assess impairment. Part of that is kind of getting a qualitative history and kind of hearing from parents and young people about what's going on. So as a general rule of thumb, it'd be like, adults and teachers are sometimes a bit better at describing ADHD type symptoms, and young people themselves are quite often a little bit better at describing the emotional content or difficulties they're having. There are, like I said, in things like CADRA, there are things like the symptom screeners. So they've got like a really broad domain, what are the difficulties that are going on here, and can be rated by parents, like I said, a bit more granularly. There are things like the teacher report form, it's the Arkenbach, and I can kind of point in the direction of that. But there's multiple kind of teacher forms that can be sent out as well for them to rate little bits. So I actually think an important point, because really what you want to find out is actually what are the impairments, or what are the impairment support needs, rather than just the kind of diagnostic label. So hopefully that answers that question for you. Do patients on stimulants need an annual ECG, BP weight as part of their monitoring? Yeah, it's an interesting question. I mean, I think it depends on the, yes, and certainly in terms of children, I would be thinking, so the guidelines would say they don't necessarily need kind of ECG echo unless there is evidence of, some sort of concerning family history about cardiovascular issues, particularly rhythm bits and pieces, or there are some issues from the developmental history. Just briefly ask about that. But I certainly with children, kind of monitoring weight and height is a major thing, and kind of blood pressures as they go through. I won't go into it too much, but I mean, there's the same thing. There's a bit of crossover with connective tissue disorders as well. And so you want to monitor things like blood pressure and other bits as you go. Who does that in terms of the GP versus the psychiatrist? I think that's one that doesn't really have, I don't have an answer to. So probably someone needs to monitor that. I would say that would be on the person who's, personally, I'd say that'd be on the person who's prescribing the medication. But if you're in some sort of co-prescribing arrangement, I don't know, maybe that has to be negotiated. The ECG thing is not an absolute, but is a pretty easy thing to do. It's just usually good documentation. So that's a bit of a wishy-washy answer, but I hope that kind of answers that one too. What has been the impact on developing young adolescent brains from electronic devices? Yeah, great question. I think that's a whole talk by itself as well. I think there are probably positives and negatives to this, in that, I mean, what you're getting from electronic devices and video games, etc. I mean, video games in particular are like the ideal thing for the brain in terms of that motivation reward system. It's like a highly scaffolded, very, very nice kind of situation that decides what level you're at and kind of rewards you with, in a multi-sensory kind of way, and as you progress on. So the reward learning part of that is like, I feel like if we could learn how to be video games, we'd be very successful with helping young people. But I think it's hard to say, like a lot of other things, is like, do people with difficulties already with those executive functioning, emotional regulation bits tend towards playing video games and looking at phones more, or is it the other way around, or is it kind of a bit of a mixed bag? I would think there's probably some, if you think about kind of executive functioning and emotional regulation as things that need to be developed, then there's probably some detriment to, something that's providing immediate satisfaction all the time, or kind of an ability to completely avoid having building those skills, or kind of. But I don't think it's as clear as they're good or bad in an absolute way. I think it's just a complicated one, but can certainly, once again, that's an area of interest. We can think about kind of electronics, and that kind of addiction model with electronics is an interesting one as well. I didn't go into that with the motivation reward cycle, but there is really one of the things that happens with habituation is things tend to bypass that frontal lobe part where people are kind of making decisions, and it turns into kind of more of a seeking model that really you having to do the other way around. You're having to try and inhibit that. That's I think we've seen substance use, but also seems to be similar in kind of internet and gaming addiction type pictures. Is there a clinical tool to assess response to medication management? Yes, so there's kind of multiple for that. And I think once again, I mean, there's probably the best way to do that, I think, would be to start off with one of those kind of symptom monitoring forms that, like I said, there are some really nice comprehensive ones, or there's some really brief ones that you can use for it. But the CADRA guidelines have some good free kind of symptom monitoring forms, and best ways to kind of use those, because then you're getting your target areas in the first place, and you can kind of monitor as things are going on. If you need to add in stuff that's more around mood and anxiety, I think there are things like the RCADs and other bits that I'm more than happy to include in the resources section as well. Okay, it is almost impossible to find anyone to take on a new patient with ADHD in WA. How do I help a patient in the long wait? Yeah, so anonymous. I think that's right. I mean, I think I agree. I think like a lot of things, it's a wicked problem. I think there's not easy answers to it. I think one of the thoughts we're having, certainly in terms of the kind of Ramsey Hollywood side of things, like what can we provide with that? I think that's why I'm pretty keen to try and connect with you as well, and think about some of the, ADHD is not just about stimulants. They can be really helpful, but they're not the be all and end all of ADHD treatment. And some of it is really about how to support with other things that are a major part of the picture, or kind of certainly exacerbating the issues as well. And that can be medication bits, or other kind of therapies and strategy-based bits. But look, I agree. I mean, the access, in terms of access to mental health care, it's a big issue in Western countries generally. So hopefully I've covered some bits of that today in terms of some approaches for people that are presenting with these difficulties. But it's a complicated question that I think we just need to keep talking about as well. I've got about 5 minutes or so. Sheetha, how to deal with patients, adolescents who come in with self-diagnosis of ADHD and all classical symptoms post-Googling? Yeah, I mean, I think this is the limitations of criteria-bound diagnoses, which is kind of DSM type and ICD type diagnostic systems, really, where they just impose a cutoff. I mean, to be fair, pre-doing that, psychiatry was awful at kind of reliability. It's just all over the place. So there has to be a cutoff. But I think going on a kind of syndrome behavioral list alone can be really difficult in terms of then slowing things down, managing people's expectations, and actually kind of doing a good job for them of figuring out what is going on for them, rather than just the label of ADHD. I mean, I think because it may or may not be more or less accurate, but it certainly is not something that's necessarily going to help by itself. And I say that in it, sometimes it can be quite helpful from a validating experience point of view, and from a kind of going and seeking the right resources point of view. But I agree. I think sometimes it's an area of interest right now, and then people are kind of like turning up with attention difficulties, and this must be ADHD, when it's the overlap with everything else is so much in our diagnostic systems. Any evidence that medicinal cannabis can help with adult ADHD symptoms? I think I won't go into that one. I think, look, what I would say about this is cannabis, we know, probably for a fair amount of people, isn't necessarily helpful from a motivational and executive functioning point of view. Doesn't that mean that's that for all people? But I think talking about kind of medicinal cannabis, I need to maybe understand a little bit more about what the question is, and that's maybe a bit of a chat by itself as well. But in a general sense, probably not. I know people like it from an anxiolytic point of view, but it actually tends to complicate things there a little bit more anyway. And like I said, from an actual executive functioning point of view, that doesn't seem to be super helpful. Mentioned condition may deteriorate in adulthood. Sorry, anonymous. If left untreated in childhood, but also incidence in adulthood is half that of the younger group, can the condition tend to burn itself out with age? Totally. I think. I mean, once again, like I said, you're not talking about a yes or no absolute kind of thing. There's a lot of mental health conditions that shift over time, including things like personality disorders, mood and anxiety disorders. There can certainly be a kind of say like kindling or build-up effect, in that, if you think about it, if work a lot with kids with eating disorders, and what I can see is they have numerous hospitalizations and actually miss out on a significant portion of their adolescent developing life, which has major effects in terms of them needing to kind of like catch up or kind of have difficulties with that as adults. But the opposite of that is generally people, adolescence is quite a turbulent phase of life for a lot of reasons. There's the psychosocial individuating type parts, but there's also the kind of like frontal lobe and general brain rewiring. So it seems to be, what's happening is that back to front synaptic pruning, where the brain's trying to make itself more efficient by getting rid of what it doesn't need. And part of that is probably that it almost like sets things up a little bit more, as in they're a little bit more or less plastic after that. But the upshot of it is people tend to have more frontal lobe functioning in their kind of early 20s onwards. And that can have a major effect in terms of emotional regulation and kind of cognitive functioning because of that top-down kind of balancing of the limbic system. You can see people in their adolescence where they're really like, like limbically driven, and the emotional regulation, sleep and everything's atrocious because it's way out of balance. And last one is, so hopefully that kind of answers a bit of that. Can we differentiate ADHD from anxiety-induced ADHD features? Yeah, look, I mean, this is, yes, kind of, but they're like a lot of things, they're not mutually exclusive in that. Once again, think about kind of emotional regulation as a part or one of the kind of areas that's in that kind of ADHD phenotype, and also just the impact of, this is a terrible analogy, but I'm going to use it anyway. It's like you sign up for a running club where you have kind of flat arches on your feet, but no one lets you have any sort of arch support, and everyone has to run the same way. That's kind of like school. Sometimes people with ADHD, where it's under-recognized. So the anxiety can also come as a result of the lack of confidence and that feeling of difficulty and not knowing how to kind of, say, like run in a way that's enjoyable and efficient and effective and all that kind of stuff. So, but in order to answer your question, the anxiety-induced ADHD features, one of the pointers that's not absolute would be anxiety-based inattention, or the kind of overthinking and everything that comes around would be more situationally based, whereas the ADHD kind of racing thoughts just all over the place is a bit more pervasive. But to be honest, that's a pretty wishy-washy kind of thing to say, and realistically, the overlap is quite high. That's the last one. Hopefully, I've 1 minute before the end of time, so I hopefully managed to kind of stick to time there.
That's wonderful. Thank you, Richard. There's an awful lot of information in there, and a lot of other resources as well, which hopefully everybody will find the time to actually go and search out. I've just put the I'll get to it again. If I can please ask our attendees to take a shot of the QR code there, and complete the evaluation. As it mentions on there, your points, or your CPD hours rather, will go straight to the RACGP for attendees on this. If there's any problem with that, I'll let you know, but you can assume that they'll go straight through. You can also email me if you'd like a certificate of attendance for this evening as well, just as to be doubly sure. So, Richard, thank you so much for the presentation this evening. Certainly a lot to take in there, and people have got your contact details up here as well, so they can certainly get in touch. That QR code goes through to your profile on the website, so people can grab that as well.
And I was going to say, Wendy, as well, look, I will send out the slides and send out the resource sheet, but if people want to leave any comments about what extra things they would want in a resource sheet, I'm more than happy to kind of add in areas and topics there as well. So just let me know.
Yep, that's fine. Please contact Richard with that, or you can contact me and I'll make sure it gets passed on. So thanks very much to everybody for their time this evening, and I hope you've enjoyed the presentation. And thank you so much, Richard.
Thank you. Cheers.
Yes.